for joining us for the Native Hypertension and Risk Through Technology, or Native Chart, and Native Center for Alcohol Research or Education, or NCARE webinar series. My name is Kara Kobacki, and I'm a research coordinator at Partnerships for Native Health, a program at the Institute for Research and Education to Advance Community Health, also known as iReach. Next slide, please. I quickly want to go over the Zoom features today. On the bottom of your screen, you should see a chat option, which you can use to send messages to all participants, or you can send a message directly to the hosts. There's a raise your hand feature. However, we ask that you please hold your questions until the end, as there will be a designated Q&A time, and please do so by typing your questions into the Q&A box on the bottom right. Next slide. For today's webinar, Dr. Amanda Boyd and myself will provide a brief overview of iReach, Native Chart, and NCARE. Then Dr. Kait Hirchak will give her presentation, and we'll end with a 10-minute Q&A session. After the conclusion of this webinar, you'll be given a chance to provide feedback through an evaluation survey. A recording of the webinar and presentation slides will also be available on both the Native Chart and NCARE websites, which can be accessed through our main page, ireach.wsu.edu, and we'll also send an email with the link as soon as they're posted. Next slide. So iReach at Washington State University challenges the status quo and advances community health through partnerships and collaboration. We conduct research in rural, Native, and Latinx populations, health networks, and populations with substance use disorders. Next slide. Our iReach faculty belong to various colleges at Washington State University, and we partner with external collaborators at universities across the country. The Institute houses 5 primary research programs, including Partnerships for Native Health. Next slide. Partnerships for Native Health conducts community-based research and education to improve health and reduce health disparities among American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. We do this by working with both community and academic partners in community settings. We focus on achieving health equity, community outreach and engagement, and training and education. We have over 60 partners across the country, including tribal colleges, Native organizations, tribes, universities, and satellite centers. Northwest Health Education and Research Outcome Networks aims to improve the quality of clinical care and ameliorate health disparities in communities across Washington and surrounding areas. And Latinx Health is advancing Latinx health through the formation of community partnerships and focused academic research. I'll now let Dr. Amanda Boyd share information on the Native Chart and NCARE, which are centers within our Partnerships for Native Health core. Next slide.
Tansy, hello, and thank you for joining us for this webinar on culturally centering evidence-based treatments. My name is Amanda Boyd, and I am an associate professor in the Edward R. Murrow College of Communication. I am Métis and Daneza from the Peace Country of Treaty 8 territory in Canada. I am also the co-lead of Native Chart and NCARE dissemination cores, and I have the pleasure of introducing these 2 NIH-funded research centers that are co-hosting the presentation. So within Native Chart, our aim is to improve control of blood pressure and other risk factors for cardiovascular disease in American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders with diagnosed hypertension. The center is comprised of 3 community-based intervention projects and 4 supporting cores. Next slide. The NCARE Center aims to optimize alcohol intervention research for public health in general, and our Native community partners in particular. We have accomplished this goal by collaboratively engaging with research project teams and with the pilot projects to conduct research that yields high quality data while simultaneously meeting the unique needs of our partners. Next slide. So we work with 7 satellite centers located in Alaska, Colorado, Minnesota, New Mexico, North Carolina, Oklahoma, and Washington. The work we do with these centers ensures that our research topics are important to American Indian and Alaska Native throughout the US, and outreach and dissemination efforts are amplified throughout the country. So now I would like to introduce our presenter, Dr. Kait Hirchak.
Thank you so much, Amanda and Cara. I'm Kait Hirchak, and I'm an assistant research professor at Washington State University. And I'm really excited to be here to chat with you a little bit today about considerations for culturally centering evidence-based treatments among American Indian Alaska Native communities. I'd like to start out by acknowledging where I'm calling in from. I'm calling in from the beautiful traditional territories of the Squaxin. It's known more commonly by its settler name of Olympia, Washington. And I also want to acknowledge where you're calling in from, the Indigenous communities and ancestors, and greet you all. A little bit of a background about me. Wanted to start also by talking about the community and tribal partners that we've had over the last decade. I'd also like to acknowledge WSU PRISM Collaborative. So the mentors that I've had kind of overlap across these different groups, but this is how I've broken it up today. So Mike McDonnell, and we have some great team members there, including Kelsey Badgett and Nina Richardson, the NIDA Clinical Trials Network. So my mentors on that are Doctors Kamala Venner, Amy Campbell, John Roll, and I will be talking about the work that we have done recently, as well as NIAAA, where my KO1 is funded, and Dr. Deidre Buchwald, the NCARE and Native Chart team. Thank you again for bringing us together today, as well as my family and ancestors. So I'm a descendant of the Eastern Shoshone tribe, and my mom still lives back home on the Wind River Indian Reservation, with lots of extended families still residing there as well. And my sister is the interim attorney general for the Eastern Shoshone tribe. And I try to get back home as frequently as I can. And here's some pictures of family and friends that I wanted to share with you. So I wanted to start out with the significance of why effective, engaging, and culturally appropriate treatments are needed among Native communities. I also, want to push back on some stereotypes around alcohol use among Native communities, for an example. So there's a misconception or a stereotype that there's higher rates of alcohol use and that this is due to some sort of genetic predisposition or something like that, but that's not accurate. So we have a little snippet of a stat here for you that's past year, but also past month alcohol use. Rates among Native communities tend to be lower than non-Hispanic whites. Depending on your data set, opioid use or misuse might vary. So sometimes non-Hispanic white communities have higher or lower. This statistic shows that the prevalence is higher among Native communities in 2019. But just wanting to highlight that this is variable by state, region, both in alcohol and opioid misuse. But with opioid misuse, there's higher fatality, especially in Washington, Minnesota, Alaska, and Oklahoma. And that Native communities are disproportionately impacted by the consequences of misuse. And, there's been an increase, especially in opioid fatalities among these communities due to COVID. And I'm sure some of you have seen and heard those statistics as well. So turning to cultural adaptations of substance use disorder treatments, this is a picture of where I'm at right now. It's not quite this sunny today, but this is a beautiful land that I'm calling in from. And so wanted to talk about why cultural adaptations are necessary. So for those of us that do this work, it's pretty obvious, but sometimes we get these questions of why is it important? And Castro and colleagues define cultural adaptations as like a systematic modification of the EBT or the protocol or the way that you're approaching it to consider language, cultural factors, context in a way that is meaningful to the new community and includes their values. So the literature has identified several areas when you might want to culturally adapt. So when the diverse population is growing and it's a new community or setting where you do want to make these modifications, as well as if there's evidence for poor treatment engagement. Engagement and retention tend to be big reasons why a lot of folks argue that cultural adaptations are necessary. You might also do it when there's unique risk or resilience factors or symptoms of the disorder, or that there's evidence that maybe the intervention isn't as effective, or that maybe it would help improve the outcomes. So we're lacking consensus on which scientifically rigorous approach to employ for culturally adapting EBTs. There are many approaches that you can consider, and so this is in no way comprehensive. I'm just providing a little bit of a sample of approaches we've used, and that also we have approvals to kind of discuss with you and share with you today. But I will say that a CBPR or community engaged approach is a must, and that this work is very process oriented. So things for you to also consider in your work as you move forward. So looking at a CBPR, for an example, if you're not familiar with that, it recognizes the community as the authority. So really, the community identifies their needs, their assets, their resources, really helps identify solutions. It promotes co-learning, and it's an empowering process, both for the community and if it's a university partnership for the university as well. And it's very iterative. So another approach that we've considered and included in some of our work relates to surface versus deep adaptations. So Dr. Lau discusses how cultural adaptations kind of more towards that wanting to address specific risk or protective factors. So that's something that you would then maybe do a surface or a deep adaptation. You know, in terms of surface adaptations, I'm thinking more of like when you just are maybe changing the treatment materials or sort of the aesthetic or the branding around the intervention. It can also be deeper. So maybe this is when you're including the key ingredients, but then also integrating more of the deeper traditions or values of the community. Another approach that we have applied in our work is the ecological validity model, or the 8 dimensions. Dr. Kamala Venner has led a paper on this, currently under review, around the importance of this framework as part of the adaptation process. So the 8 dimensions are looking at language, persons, metaphor, concept, goals, methods, context. So we'll see here in the next slide how content or persons might be more related to having a community member deliver the intervention in the native language. So that's one consideration too for your work when culturally adapting. Another thing that we think about is culturally grounded versus culturally adapted interventions. And so some people say there might be some potential tension between these two approaches. So culturally grounded, we think more of the intervention being developed within or by the community, and it stems from the worldview of the community. Folks argue that this protects against potential iatrogenic effects, that cultural adaptation might accidentally or inadvertently reinforce colonization or stereotyping within the community. So really wanting to make sure that you get away from this, like just add a little bit of indigenous and stir. So doctors Karina Walters and Joseph Gahn, for an example, are two researchers that I think of when I'm thinking more of this culturally grounded approach, or building up from the ground up. This approach can be challenging, though, due to cost or funding requirements where the funder may want an EBT. So cultural adaptations might be an alternative to this. And it's also why CBPR is so important, because the community will be able to determine what they feel is appropriate, and if something aligns with their values or not, or what adaptations are required. So this sort of cultural grounded versus cultural adaptation approach is part of my KO1 training, and I'm focused really on wanting to learn more about the considerations for these two approaches. So I just thought I would share that with you today. Okay, so I wanted to talk a little bit about the evidence for culturally adapted SUD interventions. So here's a recent meta-analysis by Hai and colleagues. And they reviewed 22 studies. So they pulled the data from these studies and looked at the trends and the magnitude of the intervention's positive effects. And so when we think of effect size and the magnitude of this, we're thinking of the difference in the outcomes between the two groups. So the effect size is basically the mean difference between like the adapted intervention and treatment as usual, for an example. So a 0.2 effect size is usually considered small. 0.5 is usually like a medium effect size, and 0.8 is considered a larger effect size. So this meta-analysis was not just specific to Native communities, but it included studies from folks from Africa, Asia, and then in the US, the population was primarily Indigenous, Hispanic, and Latinx. So as we can see, this study demonstrated a small effect size for culturally adapted interventions overall. It was small for specifically for alcohol, and then a little bit larger when comparing to essentially no treatment at all. Previous research by Hall and colleagues have found medium effect size for culturally adapted interventions. But I think that this is really awesome to see that this is an effective approach, and really that's what we're doing here. We're trying to find out for whom our interventions work. And so types of adaptations here really focused on translation, so around language, again, how I mentioned who the provider is, so someone from within the community, and then social cultural components. So yeah, we want to continue to complete this research, and I'm really excited with the work that we've been involved in, and then I'll get to share with you. Okay, so now the two brief case studies or highlights of culturally adapting evidence-based treatments that I've been involved with are rewarding recovery and centering culture and medications for opioid use disorder with Native communities. And I'm just really honored to have been a part of that. So we have a couple of papers out around culturally adapting the contingency management intervention with Dr. Mike McDonnell and his team. And one of the projects was a multi-site study of contingency management for alcohol use, and another was a single site study of contingency management for alcohol and drugs. These two CM studies are maybe 5, 6, 7 of the existing clinical trials that have been completed with Native communities addressing substance use. So I always like to take time to brag about that, because Mike McDonnell and Dr. Kamala Venner are very humble, and so they don't always highlight that fact. Dr. Venner's adaptation of motivational interviewing and the community reinforcement approach is an example of another clinical trial that was recently completed and had positive intervention effects. So talking about the rewarding recovery study, for those of you who may not be familiar with contingency management, it's an intervention where a tangible reinforcer is provided for demonstrating a specific behavior. So in this instance, drug or alcohol abstinence, the target behavior or the behavior change that you're wanting to address, you monitor that, and then you provide a reward when that behavior occurs. And we also provide larger rewards for longer periods of abstinence, and then the reward is removed if that behavior isn't met. And CM is the most effective treatment for initiating abstinence, especially among stimulant use disorder. And it's really great because it promotes relationships and connection between the relative and the provider, and it promotes, positive communication and self-esteem. And so we found that this intervention aligned well with the values of the Native communities that we partnered with. So the overall goal of the Rewarding Recovery study was to see if CM led to reductions in alcohol and drug use among the single site reservation community. And the goals were to adapt CM to maximize the cultural acceptability and determine if people who received CM for both drugs and alcohol used less of those substances. So the methods for this eligibility included being 18 years or older, self-identifying as Native, having an alcohol dependence diagnosis based upon the DSM-4, and having used an illegal substance in the last month. And then the study design, relatives were in the study for 12 weeks, and urine tests and CM rewards were provided 3 times a week. And this was a very complicated study, so I'm going to do my best to describe it. But there was 3 versions of CM, along with the control condition, who received incentives just for attending visits. And so the primary outcomes were attendance, alcohol use, drug use, which were assessed by urine drug tests. And alcohol use was assessed through ethylglucuronide, ETG, the biomarker metabolite that is excreted from your liver, and then we can assess it in your urine. And we're able to detect alcohol use for 2 days, and then higher levels of alcohol use up to 5. So this has been an awesome project, and now I want to kind of discuss some of the adaptations that we made to this intervention. So some of the cultural adaptations were around concepts of recovery. Here we can see a medicine wheel. So this medicine wheel we adapted to describe the process of being in the study, or what that might look like from the provider's perspective. And the medicine wheel is really meaningful to me and to our partnering community, where it really represents finding that harmony and balance in our lives, the emotional, mental, spiritual, physical, just those cycles of nature and the 4 directions. So this was one of the adaptations that we made, and along with kind of further down the bullet list, but we also had an elder that delivered the intervention, which made that really successful, being able to speak in your native language, and that being a point of sort of connection was really important in this intervention, as well as the adaptation of the prizes themselves. So some of the prizes, we kept hearing how important family is, and I think we all know that family is super important to us Native people, and that the prizes could be shared with families. So whether that be purchasing, items for your children, or having a family night, and also the recognition around those in recovery and their journey. So having different activities around that, whether it be certificate or some sort of feast or something like that to recognize the individual. So here we have a quote from a participant around what they how they felt about the prizes. Okay, so as I said, the complicated part of the study. So the first group was reinforced for alcohol only. So only when they abstained from alcohol use did they receive an incentive. Then the second group was reinforcing abstinence from drugs. And then the third group was very difficult because we were asking people to abstain from both alcohol and drugs simultaneously. And then, as I said before, the non-contingent control group received incentives for attending study visits and providing urine samples. So 120 people were in the study. About half of them were female, about 36 years old, slightly more than half had a high school degree or higher. About 43% tested positive for alcohol, about half used methamphetamine, and about 37% used cannabis. So this is the attendance outcome, and not surprisingly, the group that had the best attendance were those that were receiving incentives just for showing up. The group that did not do quite as well is also not surprising. They were the ones that were receiving prizes or rewards for both alcohol and drug use, so they were not coming in as frequently. The next outcome was alcohol, and we can see that the bottom squiggly line, there's a lot of squiggly lines here, but the bottom squiggly line is the control condition, and so they didn't abstain from alcohol use, but all three CM groups were more likely to abstain from alcohol use. And then looking at drug use, only the CM for other drugs and CM for alcohol and other drugs had lower drug use. So basically what these squiggly lines are saying is that those that were being reinforced just for alcohol and those that were in the control condition did not reduce their drug use. So our takeaways from this culturally adapted intervention was that people like CM and it aligned with community values. We were able to integrate language and culture in a meaningful way, that CM for drugs and alcohol worked, but there was lower attendance. So basically, bottom line is that CM for drugs in this particular study had the best outcomes. And that with the reducing of the stimulant and alcohol use, there was an acceptable level of attendance, and that in the CM for alcohol, reduced alcohol use, but not for drug use. Okay, so now I wanted to turn to another one of our projects, and this is Centering Culture and Medication for Opioid Use Disorder with Native Communities, and this project is led by Doctors Kamala Venner and Amy Campbell through the CTN study. And from this work, we have developed an initial paper around the efforts to culturally adapt this intervention. Oops. So the background of this study is that this is an implementation study looking to culturally center MOUD. Doctors Venner and Campbell are OG CVPR researchers, so very much following that process. And the study is partnering with 4 geographically diverse Native primary care and addiction specialty orgs, both in urban and rural areas. And so the paper describes the collaborative board process, and the collaborative board was convened to identify key components of culture, that are needed to center the implementation of the intervention, introduce and tailor implementation science strategies, and build partnerships with the academic research team and the collaborative board and the partnering sites for bidirectional learning. So from their study, as I said, we developed a paper using a CBPR process. We convened the collaborative board just to help frame and guide some of these initial cultural adaptations of MOUD and just gaining their perspective from leaders and experts in the field. And so over about a 3-month period, Kamala and Amy and the team reached out to individuals, their networks. They received nominations of people that would like to serve on the board. And so there's about 26 people and organizations involved, and these include physician prescribers, behavioral health, Native people knowledgeable in tradition and healing and worldviews, folks with lived experience, elders. There's just so many great people on this collaborative board. I cannot say that enough. So we had an initial in-person meeting, which was held in ABQ. And I was actually completing my postdoctoral training with Kamala Venner at that time. So I was able to attend, and we had a 2-day meeting in October of 2019. So the methods for this paper, and I really encourage folks to consider this in their own work, but we completed a Res Cafe method, which is an adapted version of the World Cafe, and it's a qualitative facilitation method, kind of thinking about how, you know, we have these deep discussions in these social settings, so like a cafe, for an example, but we found that this approach is culturally congruent because it's a collaborative process and it allows for meaning making together in a creative way. So, you know, you can write things down on paper, you can talk about it, you can draw pictures. So it's just really great approach. And for this, we set it up at different tables with about 4 or 5 people, and each table had a question and a theme to kind of discuss for about 15 minutes, and all of the conversations were recorded. And then the other piece to this are mind maps, which I love mind maps. They're very common in Native communities. I'm finding not so much outside of Native communities. But essentially the theme or the question is placed in the center of like the paper or the flip chart. And then the primary theme branches out with a bunch of sub-themes off of the primary theme. And actually, I will show you what this looks like since it also became a part of our results from these discussions. And then the data was the transcripts that were independently coded by 3 coders. And then we also had assistance with the interpretation of results from the collaborative board. So some of the questions we were kind of looking at were around causes of OUD, what are the strengths of Native communities, how can we present traditional ideas of holistic health to people with opioid use disorder, OUD, how do we integrate traditional healing practices in a holistic way, what are some traditional thoughts around pain. So we had some really great sort of prompts. So from that, we identified basically 3 overarching themes. So the first related more to the complex causes of OUD. So the collaborative board highlighted how when we're centering MOUD, we're really going to want to consider factors related to mental health and the healthcare system itself, how overprescribing really impacted the epidemic in Native communities, how individual level factors like stress, depression, and low self-esteem might impact, history of childhood trauma or intergenerational trauma, lack of social support, stereotypes, stigmatized. So they just had a lot of great ideas. But the two parts that I would like to focus on are these next two bullet points, which is around Native cultural strengths and integration of this into MOUD, and then the similarities and differences when you center treatment versus holistic wellness. So here's the first mind map, and it's focused on strengths. And so the primary themes from this, we can see branching out, are family, healing, networks, religion, spirituality, storytelling, and hope and acceptance. And so some examples that we want to consider around family for the intervention would be really focusing on resiliency, our clan and kinship systems of support that we have, just being really compassionate and open. For healing, we had some examples here. So maybe some sweat lodge or ceremonial activities, having events or crafts, networks. We have social support, the tribe, of course, passing on traditional knowledge and the importance of cultural survival, spirituality, again, kind of around ceremony and teaching. Of course, with hope and acceptance, we can't forget about Indian humor. That's such an important medicine for us. So just really considering these pieces as part of the process and integration of these strengths into the final intervention was just really highlighted from this discussion. So this mind map is when we're centering the holistic wellness versus this map, which was when we're centering MAT. And just a note that at that time we were using more of the MAT language. Now we're using more of the medication for opioid use disorder language. So with the holistic wellness, we see that there's much more around the different themes and sub-themes. And so we have spiritual teachings, cultural values, you know, the needs for all of that to include you know, like food sovereignty of the teas and herbs and all of that, elders. Some of the similarities and differences between the centering holistic wellness on the next slide. The holistic wellness emphasized more of the importance of family involvement in elders, whereas the other map, it was more around education and removing stigma. And so although both maps included elders and some spirituality, I think wellness was much more at the forefront when it was centered. And so we have about 28 sort of themes and sub-themes here versus 17. But removing stigma seemed to be very important when thinking about MOUD specifically. So from that work, this paper, we found that implementing MOUD should really focus on a strength-based and holistic approach. It should be engaging with recovery strategies and integrating extended family and traditions and really addressing stigma and building trust. Integrating traditional healing practices, ceremonies, and other cultural practices as well is really important. And then just the common theme threaded throughout this entire project, and then also the rewarding recovery, is the involvement and importance of family. Okay, so I wanted to talk about dissemination and implementation a little bit. The rewarding recovery study, we had a little bit around that, but primarily the centering culture in MOUD is an implementation study. So I'm really looking forward to learning more about that as we move forward. And D&I is another important piece in culturally adapting EBTs, I think. So I wanted to kind of talk about some of the recently published work that we have around this and that I've had the good fortune of being a part of. So doctors Lorinda Ballone and Neil Wallerstein have some new projects, kind of integrating CBPR in a D&I framework. And then, as I mentioned, some work with doctors Benner and McDonald. But D&I is a growing area of research in Native communities, and it really has the ability, I believe, to improve treatment outcomes and increase health equity. So dissemination and implementation, when I'm thinking about this, I'm sort of thinking of translating research to practice and really addressing the gap between the two. And so there's a lot of frameworks and theories and models around this, but how best to translate the EBT into a real world setting and make it something that is accessible and used by communities and practitioners. So recent efforts have really focused on scaling up interventions and building capacity of Native communities to conduct their own research. And so that really speaks to the first two kind of points on this slide here. And then, CBPR, of course, very central to this. Doctors Rasmus and Weitzel, two are other researchers who have really moved the D&I science forward and doing this in a way that's partnering with communities and can be applied to both culturally grounded interventions as well as EBTs that are culturally adapted. So CBPR is essential to advancing D&I frameworks. And when I've had some conversations around this with Dr. Wallerstein, I had always kind of thought of CBPR as a D&I kind of strategy, but I've come to realize that it's not always thought in that way. And so right now, Dr. Ballone and Wallerstein have an R01 that's really helping to outline how CBPR can help to inform D&I efforts in Native communities. And so they've identified the interactive systems framework as an example of an existing D&I framework that they are adapting within their community. And they see that D&I framework as important because it's translational and it can bridge the various levels of uptake, cultural acceptability and sustainability of EBTs. Since there's a lot of complexity in Native communities, a lot of factors that impact health, so policy and tribal government and all of that. So they're currently working at adapting that and integrating CBPR. Another thing from the D&I literature, F. Scoffey and colleagues have noted that less than half of D&I implementation frameworks are used to guide research. And so there's a lot of areas for improving this. And so another idea around D&I is developing your own framework within your community or adapting it from a Western sort of approach. I believe that more so than in other communities, Native communities really need effectiveness in D&I studies to impact health outcomes related to what I was talking about before, the implications of sovereignty, multi-level systems, and the policy implications of that. So I'm really always talking about how happy I am, that there's been this interest in D&I research and funders are continuing to embrace and recognize this and value hybrid studies where both effectiveness and D&I outcomes can be examined simultaneously. So I just kind of recommend, letting culture guide the research, really considering sustainability during the intervention implementation, as well as identifying the frameworks, theories, and models that best align with your community or the community that you're partnering with. So I just wanted to close with thinking about resiliency and how important it is to emphasize strengths of our Native communities, because we have so many strengths. And I really like this quote from the Northwest Portland Area Indian Health Board around their efforts to address opioid use disorder. I think that, while some tribal communities have decided that Western cultural approach to health and healing and recovery are needed, I think we also need to acknowledge that Western-based approaches to treatment, have been steeped in racism and structural racism. And so we just want to make sure that we're not, inadvertently reinforcing these narratives. Many of our Native relatives find that these approaches, Western-based approaches can be beneficial, but without culture and spirituality, it may not be as effective for others. And so this is why culturally adapting is so important. So yeah, thank you again to the NCARE team, Native Chart, and IAAA. And then also I'd like to acknowledge that some of the graphics that I used were developed by Gobs of Color. So I will turn it back over to Cara.
Great, thank you so much, Kate, for Dr. Hirchak, for the wonderful presentation. I'd like to invite everyone to please ask any questions for Dr. Hirchak in the Q&A box at this time. Got a thank you, Dr. Hirchak, for the presentation from someone. And yes, you will, we're going to have the PowerPoint along with the recording once it's posted. So we'll send out a link afterwards for everybody.
Well, thank you again. I just want to say that this was a really great experience, and I know that you all put a lot of work into it. So I appreciate everybody attending and for your attention.
Thanks, Dr. Hirchak. We do have a question that just came in. Thank you for this wonderful presentation. Could you remind us of the PIs on the R01 that's investigating the interactive systems framework and CBPR plus D&I?
Yes, so I believe that's being funded through IRENA, and the PIs are Lorinda Ballone and Nina Wallerstein.
Just a few more minutes to let anybody put any questions in there. We have lots of thank yous, Dr. Hirchak. All right, well, if I don't see any other questions come through, I'll just give my little closing. And if I see any other questions while I do that, we'll jump back over to those. So please continue to ask if you have anything. But I just want to thank you again for speaking with us and being here today, Dr. Hirchak, and thank you to everybody for attending. Please remember to complete there's a post-webinar evaluation survey, which is super helpful for us in creating our future webinars. So please make sure to complete that if you can. Dr. Hirchak, I'll just have you go to the next slide if you can. There's one more. Thank you. So we have both of our website here, ireach.wsu.edu. And if you have any ideas or suggestions for future webinars, you can always email us at native.chart@wsu.edu. And then we have one more slide. So our next webinar will be on November 18th at 11 a.m. Pacific time, titled Working with Tribal Communities, a Framework for Allies and Partners by Cole Alec. We will send out more information soon, so keep your eye out, and we hope to see you there. I don't see any other questions for you, Dr. Hirchak, but just lots of thank yous, and that these are great to keep in mind for future practitioners. So thank you so much. Thank you to everyone for attending, and we hope you have a wonderful rest of your day.
Thank you so much.